expertise is changing. So there's a lot happening. So I want to leave WHO Afro in 4 months, pass it over to the new regional director that will be elected in a way that he can pick up the ball and run with it. And so that our organization is really in that place that, we're ready to confront the many challenging internal and external circumstances that we face. But in everything we do, our focus will be the same as we have in the last few years. Dr. Tedros has led critical changes within the organization, focusing our entire organization on serving countries. So we've had a very focused agenda where both WHO HQ, WHO in our regional offices, all have a very laser-sharp focus on making sure that our country offices are best placed to access the resources of the entire organization to serve our member states. And I don't think there's any better country that played out than during the recent Marburg response here in Rwanda, which saw all of us mobilizing to support the government of Rwanda through our country office, which Brian led so effectively, and enabled an excellent response. And now we will take that learning to any other place where we have those incidents. But our work is not only in emergencies, whether it's driving maternal health, health financing, the many very complex landscape, developing systems. We just spoke about primary healthcare. There are many other challenges, but so we have to, in a way, do both at the same time. Focus on being ready for any emergencies, but not lose track on the very important developmental work that we have to do for the countries that we serve.
Excellent. Your turn, your questions. Since you started before, let's give a chance to the gentleman on the left.
And hello, everyone. My name is Adolphe Shimge. I'm from IVG Media. I need to ask you, how can African governments and health organizations balance urgent outbreak response with the need of addressing long-term health priorities like non-communicable diseases and universal health coverage?
Thank you. Maybe, Brian, I'll bring you in to give a real example of how you're doing that in Rwanda, and I can follow up on you with you.
Thank you very much, Chikwe, for asking me to add. So, as you know, at WHO, we support the whole health sector. And when we talk about universal health coverage, as Dr. Chikwe has emphasized, it's not just about, or you can't separate universal health coverage and dealing with emergencies. The reason is you need a resilient health system to be able to respond to outbreaks and emergencies. So the two have to be basically the same. So if we look at Rwanda, I think we already heard about the excellent work that government has been doing and the work we've been doing with government to help them in terms of their planning, basically developing strategies. So as you know, the government develops a national development strategy. And then we work with ministry to develop a health sector strategy. And then from there, we help them develop specific strategies to cover all program areas. So that then ensures that you're covering all of the aspects, ensure that the health system strengthening, having a resilient health system, because it's only when you have a resilient health system, as we saw during COVID. And these are the lessons that Rwanda learned and has been able to implement with regards to Marburg, because we have been working with them in strengthening their systems. And when it then came to the Marburg response, the government was able to do that. For example, they have worked a lot on their primary healthcare system. They have one of the strongest primary healthcare system, and they've continued to work on that. And we have been working with them as WHO. They have been working on other aspects of resilience. Minister talked about community health workers, which was a critical piece that government has been working on. So it's making sure that as government works on their health programs, it's balanced. It addresses both preparedness and response and prevention, but also focuses on universal health coverage, which includes all the other aspects. And that's what we've been doing, working with Rwanda to make sure that it's balanced. And we can see then the results that come out of there. Rwanda had one of the best COVID responses. Rwanda during Marburg was able to control the Marburg outbreak with partners, with support of partners within 90 days, and had some of the best indicators, 23% case fatality rate. That's one of the lowest in all of the outbreaks. They were able to make sure that patients were taken care of very quickly. We were able to mobilize even resources from outside Rwanda, from other countries. And so I think those are some of the lessons that we have had with a balanced response that doesn't just look at emergency, but realizes that health, you actually have to work across all the sectors. Chico.
Thanks, Brian. Excellent example from a Rwanda context. But maybe a few examples beyond Rwanda. If you think about during COVID, one of our biggest challenges in many countries was access to medical oxygen, right? And since then, we have worked with countries around the world, on the continent, to improve access to medical oxygen. Now, oxygen is not only a requirement for health emergencies. In fact, most of the time, it is required for non-emergency situations, for women giving birth, for emergency surgeries. So interventions that were highlighted through the pandemic led to the identification of a gap. That gap is now being filled around the continent. If you look at the diagnostic infrastructure in almost every African country, molecular diagnosis, pathogen sequencing was a rarity. There were a few countries that had this capacity prior to the pandemic. During the pandemic, we've learned how to do that. We've scaled rapidly, and now almost every country has that. And it's not just using it for emerging infections, it's using it to manage all diseases, even the endemic ones. So never lose a crisis. Every crisis presents an opportunity to develop systems, and those systems will prepare you for the next crisis, but it will also support you in managing the patients that come through the facility every day. And just to conclude, no health system can survive, can be credible if you're only ready for emergencies. The healthcare workers want you to support the health of their children when they have malaria, when they're undernourished, where they have any health problem. And that way they have confidence. And so when there is an infectious disease threat, there's already confidence in the system. And so our work is never one or the other. We have to do both concurrently in every country around the world, which is never easy.
Excellent. Thank you. You're next. Pink, the lady in pink.
My name is Mercy Kahenda, a health and science journalist with the Standard Media back in Kenya. My question goes to Dr. Chikwe. You've spoken more about outbreaks and preparedness, and my question is about how is WHO enhancing early warning on these preparedness, because we've been having lots of outbreaks. How is WHO enhancing these early warnings to African states? Then on funding and sustainability, how is WHO planning to mitigate the impact of reduced donor funds on critical health programs such as immunization and epidemic responses, bearing in mind we need to have to remain despite challenges facing Africa? Thank you.
So thank you very much. Your first question was on early warning systems. So for many years ago, WHO developed a system called Epidemic Intelligence from Open Sources, EIOS, which complements national surveillance system. This system now works in 120 countries around the world, but it is actually implemented by national public health authorities. So ultimately, the international health regulations, which guides our work globally, is a treaty among countries to detect and share information on threats that they find. What we do is coordinate, provide a platform, and enable them the opportunity to share that information in a safe way so that nobody has negative consequences from that sharing. It's a system that has worked many years. There was an amendment to it recently at the last World Health Assembly. So every country has to develop its own mechanisms to collect information, detect and respond within its own context, and share that which is necessary to be shared to its neighbors and the broader global community, which works fairly well. Of course, it's dependent on, firstly, the ability of a health system to develop threats. So in Uganda, in Rwanda, this will be done by the Rwanda Biomedical Center. In Nigeria, it will be done by the Nigeria Center for Disease Control. In Liberia, it will be the Liberia Public Health Institute. So every country would have its own agency that is primarily responsible for this. And then it will be shared globally. I think on your second question is very important, and this, you're really asking about the impact of the loss of funding to the work that we do. I think this is a very important question and one that we're all struggling with at the moment. But the message, consistent message across many countries and many partners is that every country has to invest a little bit more in its own systems, in developing its own human resource, its own institutions to do the very important work that they have to do. No country can afford to outsource its responsibility to its people. And this is a message we have been giving consistently. Organizations like WHO that I work for are there to support you so that the tools that we develop to do this work, not every country needs to develop its own tools, its own data sharing platforms, its own understanding of the science. So our role is to collect the global evidence, collate it, offer it back to countries as the best practice in whatever we're doing. But the investments in how to do it, how to prevent this, how to assure that people in every country have access to primary healthcare, that disease control programs are funded so that countries can provide vaccines, antiretrovirals, TB drugs, whatever medicines are primarily the responsibility of countries. But it is very inefficient for every country to do it on its own. So that's where global organizations come in, and that's the primary role that we would like to continue playing. So any cut in funding on any of those levels will have an impact on the efficiency of the entire system. So reduction in funding in X would have an impact on Y. And that's why health is so tricky. The consequences of the actions today might be quite severe in somewhere that none of us would have imagined. Let me give you a simple example. Every year, a new influenza vaccine is developed every single year because the vaccine is very variable, right? For that vaccine to be developed, it requires samples to be collected and shared from every country around the world. And together, we develop the best vaccine for the world based on the samples collected from around the world. So if we're not able to collect samples from around the world, we're not able to advise companies on the best vaccine to develop. If we then have an influenza epidemic, it may end up affecting those that need it the most. So in the space we work in, we are all mutually dependent on the work that we are doing in the different countries around the world.
Excellent.
Could I
Fine.
maybe add very quickly on the first question with regards to enhancing early warning systems? Let me just add also that the AFRO, the regional office, has developed a system that has now been adapted elsewhere, which is the integrated disease surveillance system. And what we have done, in giving an example in Rwanda on how we are ensuring this enhances the early warning, is this system was initially for human health. And the system was set up. Rwanda was one of the countries that adapted it very quickly, did the capacity building, and started utilizing it. and also went to make sure that this was digitized, to make sure that it was fast. So we have been working with the Ministry of Agriculture here and other partners like FAO to help set up the same system for animal health. Because if you don't address or you don't do early surveillance among animals, as you have seen with many of these are diseases that are spreading from animals and wildlife into humans. So we have been working with Ministry of Agriculture and Ministry of Health, providing the technical assistance to build the same system. And so this is some of the work that we have been doing as WHO and working with countries like Rwanda to strengthen the early warning systems so that we can pick up outbreaks earlier and respond better. Thank you.
Can you hear me? Oh, thank you. I'm wondering, Dr. Chikwe, if you can comment on the US pulling out of WHO and how that could impact, in particular, WHO Afro. And then to bounce off the commentary you made about, like, I think to the effect of never waste a crisis, kind of saying, when you gave the examples of during the pandemic, there was this kind of increase in kind of the prioritization of genomic sequencing and local manufacturing. Do you see that kind of the impacts of what's happening right now could kind of spur similar initiatives?
So thank you. I think the first question is, where the impact on the withdrawal of the US from WHO. We remain open to a rethink of that, and we're continuing to engage. We have worked with US colleagues, with the US CDC, with colleagues in many organizations for many, many years. We still believe that work is very important for the world, and we would wish a situation where we are able to continue collaborating. On the second question, I gave those two examples of the opportunities that came from the crisis that led to specific developments in a technical area. The current financial crisis, let me put it that way, because the impact is not only on WHO, it's on many countries, substantially dependent on donor funds, many organizations that were providing critical services. I do think that we have to look collectively on how we finance our health systems. And this is not a hypothetical situation. Many countries, if we're able to fund the building of our roads, bridges, airports, seaports, there's no reason why African countries cannot fund the provision of vaccines to our own children, antiretrovirals to our own patients, family planning products to our own wives, mothers, and sisters. Yes, there are many things we can do together and share resources and share opportunities. But I do think there is an opportunity now for many countries to look for opportunities to bring more financing into their own systems, and WHO is ready to support them, to learn from other countries, learn from other regions where this has happened in the past. And, I think, again, Rwanda is a great example where that has happened. Community health insurance is an excellent example of how you mobilize resources, pool those resources, and enable access for people. When I visited Rwanda many years ago, a very good friend, I asked him about his private health insurance, and this is a fairly well-to-do colleague, and he told me that he really didn't need private health insurance in Rwanda, that he was confident that the public health system can provide him the care that he needed. And that's a story that I wish to see every other African country to tell.
My question is, Africa is still finding a challenge in accessing vaccines, especially when we get outbreaks. And don't you think it is high time for WHO to empower and support these African countries to start making their own vaccines. I'll give you an example in Uganda, how we are doing it with Ebola.
So thank you. I think that there's probably no space that is more exciting at the moment than the space for local vaccine manufacturing. And in fact, the space for local research and development for all medical products. I wouldn't just limit it to vaccines. We talked about, and there are many components of this. In the previous session, we talked about the regulatory environment. You can't produce vaccines if you don't have the regulatory environment. So we have seen how Rwanda is moving on that. We need a research and development ecosystem. So when people talk about vaccine manufacturing, that word manufacturing is a little bit a misnomer, because it gives the impression that you're manufacturing by building brick and mortar infrastructure projects. It gives the impression that this is a building assignment. It's really not a building process. It's a research and development, it's a scientific endeavor, mostly. Of course, you need some infrastructure, but at the heart of it is how you take products from discovery to trials to deployment, which is more or less the beginning is mostly a scientific endeavor and then a public health endeavor. And so it's a long-term process. I'm excited about progress being made in many countries around the continent, but not just in the manufacturing space. In Nigeria, there's government is really focused on something called the sector-wide approach, where they are specifically investing in the development of many other medical products, from medical syringes to bed nets to all these other products that we now need to activate the market on our continent so that the resources being spent to purchase all of these items help in our country. So Uganda has one of the most developed medical research and medical training facilities on the continent. We're all proud of Makerere University and the expertise it has developed. Many colleagues in my generation that grew up in the era of HIV and AIDS really learned from the work done by many scientists out of Uganda. And we really hope that there will be an opportunity now. I know we're challenged with a few outbreaks recently, including the Sudan virus outbreak, the variant of Ebola happening right now. But so far, I've been very intimately involved in the response. Our colleagues are there. There's been a recent setback in the case that was detected, but the response really shows how diligent colleagues are in being able to understand what needs to be done and also deploy it. And most of the response is actually being driven by local researchers, local public health experts, and very proud of the response in Uganda specifically.
Excellent.
Can I just add?
Oh, sorry.
Just very quickly. I think just to give one specific example, which Dr. Chikwe mentioned in his presentation, the work that we have been doing as WHO in supporting countries, or Rwanda. Regulatory area is a very critical one. And you need local regulatory authority to have the capacity to be able to regulate. So in Rwanda in 2018, Rwanda basically set up their Food and Drugs Regulatory Authority. And so that was very, very recent. And we as WHO have worked with them over the years to build their system to be able to make sure that they reach the maturity level 3, which is recommended by WHO. And we help them do assessments. We help them develop plans on how to improve their system over the years. And end of 2024, WHO reassessed them and found that they had reached the maturity level 3, which is a level where they are able to regulate. Of course, because we don't have manufacturing of vaccines yet, we don't have manufacturing of drugs yet, which is a process that's starting, but they were judged to be ML3 as a non-manufacturing country. So this is one example of how we as WHO have worked with one specific country to help build their capacity. And we are now working with them on them strengthening their capacity as a manufacturing company. So there are a number of, as a manufacturing country. So there are a number of areas where we have worked, but I just wanted to give that as a concrete example of how we have been supporting countries. And of course, we're working together with Africa CDC. We're working in the context of AMA in supporting those processes.
Okay. Thank you very much. We are sorry. If you don't mind, I need to take a question online so that we don't leave them out. So what strategies, this is a question coming from, I think, Flavia. Does WHO have for the gaps that will be felt in the key research work that has been or was being funded by USAID research?
So there's the gaps at the moment are widespread in so many areas of endeavor, right? So our first responsibility is actually to understand fully where all the gaps are. They go from delivering of life-saving antiretrovirals to research to health worker training, and the impact is different in different countries. Some countries are dependent to different extents. So our first responsibility as an organization is to understand the impact on the countries we serve, and then work together to mitigate the most acute effects of that. One that is fairly easy to explain is a global drug facility for TB, right? Where the US government has been the primary funder of the organization and the mechanism through which TB medicines are procured globally. And when you do global procurement, you drive down prices. And that has really enabled access to many patients every day around the world, a lot of them on the continent. So there's a significant impact on many programs like that. In many cases, we're not certain whether the funding is suspended or stopped. So a lot of this is still being assessed. And over the next few weeks, we will continue to do this, understand where an immediate intervention is necessary, where a longer-term intervention is necessary, and who the other parties are that can come together and support each other. But let me end with a statement of hope. I think in many crises that we've had, we've been positively surprised at the solidarity that we have seen. If you think about the first few months of the COVID pandemic, in almost every African country, we saw people coming together, we saw communities coming together, we saw countries coming together. On the African continent, I was in Nigeria at the time, and I remember working very closely with John Kengerson, who was leading Africa CDC at the time, with WHO, Afro, with Dr. Moeti, and we thought about solutions. We moved reagents from one part of the continent to another. We shared our knowledge, we shared our science, we came together. I do think that I'm very optimistic that we will find this challenge will trigger a solidarity response within our countries and between our countries, and that we will come out of this stronger than ever before as we own our problems and own the solutions and work with our friends to find a sustainable path into the future.
Good. So we'll give you 1 minute to ask the question and request a response in 2 minutes so that we stop on time.
So Dr. Chikwe, a recurring theme, throughout the presser has been we need to look inward. That's everybody saying we need to look inward. And Dr. Sabine gave us one example. So as WHO, what other inward, besides interrogating where the leak is, would you advise African countries to look? How further inward should they need to look?
So thank you. That's a very important question. And I'll answer it in two parts. Firstly, the need to look inwards really means to invest in the things that matter, right? Now, this vaccine has captured the imagination because of the obvious gap. It was very hard for many of us to sit at homes and watch on TV late 2020 and see people being vaccinated around the world, and while we didn't have access to that vaccine. So, and because it was such a shared experience, it really captured the imagination and has driven a lot of investments. Now, if I had a perfect vaccine manufacturing facility in any country right now, it doesn't mean that I have the expertise to run it. I have the regulatory environment to run it. I have the human resources to be employed in it. So the investments can't only be in one. It has to be in the science, in our educational systems. Are we building the students through primary, secondary, university that have the curiosity that are needed to become the scientists that we need into the future? Are we working with other countries to develop the regulatory agencies? Are we developing the products, the primary products needed in vaccination, in vaccine manufacturing? Are we paying our public servants enough? Universities paying the researchers enough to keep them in African institutions, in the Makerere universities of this world? Are they able to stay there with the salaries that they're earning without being attracted by other institutions? So I say that because there's no one solution to this when you talk about looking inwards. It's really about raising the bar in our collective ambitions for the continent, and then working collectively to raise that bar with all the different pillars. But I said I'll answer it in two ways, and the other will be much shorter. Is looking inwards doesn't mean not working with others, right? So they're not mutually exclusive. So yes, we have to look inwards and we have to build, but we have to collaborate more aggressively than ever before with everyone else. And I think it is in that intersection between local entrepreneurialism and, if I could call it that, an international collaboration that we will find a sustainable future that will serve our continent well into the future.
I think that's a wonderful statement to conclude the conversation on. And thank you very much for being here. And thank you very much, Dr. Chikwe, Dr. Brian, for taking the questions. Thank you.